Hey guys, Ryan Wyatt back with you, here to talk to you today about pharmacology. Always a difficult block in paramedic school. You know, students, they see all these books and they see all these meds, the drug profile list, and they say, how am I ever going to remember this, right? So I have some tricks of the trade today to help you try to remember this stuff. I mean, think about it. We can give aspirin for chest pain. I can give rocuronium to paralyze you. However, I can't give you Motrin if you have a headache. So how do we keep all this together? How do we put this together, commit it to our memory, pass our exams, and more importantly, keep our patients safe and alive out there? So follow me on this little pharmacology journey, and we're going to go through some of this stuff, okay? Basically, what we're talking about is pharmacology, the study of drugs, just in a nutshell, all right? Well, there's a lot of drugs we have to be responsible for. There's a lot of drugs that patients take that we may not give, but we should still have a fundamental knowledge of knowing. So when they say something like, oh, I take X amount of drug for my pheochromocytoma, and you don't just go, okay, you kind of Google it and look it up real fast, right? That's how I would do it sometimes. But to remember these drugs, I think I have a couple of suggestions for you and some little helpful hints. This is certainly what I do in life. This is what I did when I was a paramedic in school. This is what I did in the helicopter, and this is what I did in combat. The first thing that I like to teach is spaced repetition. And if that's a new word or a new phrase for you guys, basically in a nutshell, it's short bursts of learning, gradually reviewed at increasing interval levels, okay? So you take a medication, and we're going to talk about epinephrine today pretty extensively, and so you just, epinephrine, what is it? What class is it? Give me one dose, and then you think of the dose, and then you put it away, and then you go back and you hit the epinephrine again, and now you know what it's called. You should remember the class, and if not, you study the class again. And then, what's the dose? Well, give me an indication now that I could use it for. Put it away. And then a couple hours later, maybe the next day, grab that epinephrine again. So it's short bursts of learning, gradually reviewed at an increasing frequency. And this, every study has shown, man, this is great. This is how you retain information long term. Not just to pass your exams here at Pima, but to save that patient's life 5-10 years from now. Number two, I like to do body systems. I like to think about body systems. If I'm going to give a medication, where's it going to work? First of all, why is it going to work there? How does it work there? And so that's the whole pharmacology that you'll learn, pharmacokinetics, pharmacodynamics in the class. Scenarios. I'm going to hit on this in a little bit here, but scenarios. Literally, you walk around, you're watching a commercial, you know, you see a guy running. If he had chest pain, interject in that scenario. Could he get aspirin? Maybe he needs nitro, maybe he needs fentanyl, you know, for his chest pain or something like that. That comes back to your spaced repetition and body systems. And so you're hitting this over and over. And pretty soon, you're walking around Walmart and you're saying, hey, if I had to treat that patient right now, what would I give them? Because literally that's what I do. And then hands-on. There's a lot of learners. I'm one of them. I have to touch this thing and see it and feel it and look at it and poke needles through it. And then I incorporate all this into my scenarios for my body systems. And once again, I've hit my spaced repetition. So, you know, by the time I'm done, I know that drug inside and out. So let's take a little journey on our body systems, okay? And I do this in paramedic school when I teach pharmacology. I love teaching pharmacology because as a flight paramedic, you have to be, you know, medic, critical care. You've got to be some type of a pharmacist, a little bit of an anesthesiologist. And so pharmacology is really our foundation, okay? Anybody can put somebody on the monitor. Anybody can do a large bore IV and transport really fast to the hospital. However, knowing some of these drugs can mean the difference between life and death. So we're going to try to break it down and make it easy. Let's take the heart, for example, as one body system, okay? Pretty important body system, I think you all would agree. What I like to do is I like to get the picture of the heart up here. Obviously, those of you who know me, thank you, Devin, that is not my artwork. And then I like to take a marker and I cut the heart in half, literally separating the atria from the ventricle. So let's just cut this heart in half. We have drugs, when we talk about pharmacology, we have drugs that only work in the atria and only work in the ventricles, and then we have a few crossover drugs. So let's start with a very common presentation, SVT, supraventricular tachycardia. Just as the name implies, supra, so above, ventricular, above the ventricle, tachycardia. So it's a very fast narrow rate, because you'll remember from cardiology that the atrial rate, if it's atria, we have a narrow complex, QRS, right? If we have a wide complex in the ventricular, well, we have a wide complex. So V for ventricular. Well, we're talking about supraventricular tachycardia, a narrow complex. Usually you can't see P waves, and it could be a rate above 150 to 160. So we'll put SVT over here. So SVT. Well, what is our hallmark drug for SVT? A very common drug we give to adults, pediatrics, and it's given at a very fast rate. Probably the fastest drug you will push in your paramedic career. Well, that drug is called adenosine. So I would have adenosine in my atria. And the dose for adenosine is 6 milligrams, rapid IV push. I mean, it is fast, okay? And if that didn't work and they were still in that SVT, we double it. So we just go right to 12 milligrams of adenosine. And you'll learn in school that adenosine is a naturally occurring nucleoside. It's an endogenous nucleoside. Nobody's allergic to adenosine. We have it circulating around. So this is a good example of one way to learn. And so you can think of SVT. And every time you hear SVT that needs drugs because they're stable, I think SVT, adenosine. Supraventricular tachycardia, adenosine works in the atria, 6 milligrams rapid IV push, followed by 12 milligrams rapid IV push. All right, so let's hit another one, just to kind of do spaced repetition on a body system, give you a scenario, and we're going to keep going with some hands-on later. So another common thing we see in Arizona, another rhythm that we see, is atrial fibrillation. All right, just as the name applies, right? Think about it. Slow down for a second. Atrial fibrillation. So where's that going to be? That's going to be in the atria, right? So we call it AFib. Okay? And atrial fibrillation, basically the atrial rate is fibrillating. We're not going to see P waves. It has these fibrillation waves followed by a narrow complex, once again, because it's in the atria. So basically, the atria is just fibrillating really fast, 300 to 600 times a minute. Well, we know one of our hallmark drugs now for atrial fibrillation is a medication called diltiazem, or cardiazem, okay? And the dose, so I'm going to write here, diltiazem. Because it is an atrial drug, it's going to come in the atria, and we'll teach you in school, the dose is 0.25 milligrams per kilogram. All right, and that's going to average out to about 15 to 20 milligrams on most adults. Well, diltiazem is the exact opposite of adenosine. It's a super slow push drug. We're talking over 3 minutes, okay? So adenosine, super fast. And you can think about that. Adenosine, SVT, super fast. AFib, the atria is going super fast, but luckily the ventricular rate isn't going 300 to 600 times a minute, or they wouldn't probably be alive. So we use our diltiazem. It's a calcium channel blocker, all right? So let's review this. Spaced repetition. We have an atrial rate, atrial fibrillation. It's in the atria. I've cut my heart in half. My atrial rate's going really fast. My ventricular rate is probably going really fast. You know, we don't usually treat it unless it's above 130 or they're symptomatic. But we're talking rates anywhere from 130 to 200, and that's very fast. So I'm going to give it a pure atrial drug, and that is diltiazem, or cardiazem. And the dose is 0.25 milligram per kilogram. We have a second dose, just like adenosine, which was 6 milligrams, and then 12 milligrams. We have a second dose at 0.35 milligram per kilogram. So my second dose, if this didn't work, after about 15 minutes, would be 0.35 milligram per kilogram. This is an atrial drug, all right? Well, what about the ventricles? We need to start talking about some ventricular drugs too. Well, I told you that ventricular, the rhythm is going to be wide, so V for ventricular. Another spaced repetition way to remember. You see a wide complex, you should be thinking it's coming from, or the origin is the ventricles. So we'll talk about one that we see, let's say PVCs, right? Premature ventricular contractions. Okay? So premature ventricular, it tells you in the name where it's going to be located, contractions. And everybody probably has a PVC now and then. You're walking down the street and you're like, oh, that's kind of weird. You probably just do a PVC, but it doesn't need treatment. But there are times where it does need treatment, okay? And when we have multifocal PVCs, we get more than 6 a minute. The patient's symptomatic, they're not conducting, so their heart rate, their atrial rate may be 100, but those PVCs aren't conducting, so their ventricular rate, which is actually their pulse, is 52. So I think, wow, what am I going to do for that? Well, I've cut my body system in half. I need a pure ventricular drug. And so a drug we can use for these PVCs that is purely a ventricular drug is lidocaine. So we have our PVCs over here, and we have lidocaine at 0.5 to 0.75 milligrams per kilogram. Very, very minimal math. You know, 0.5, anything times 0.5 is actually pretty easy to do. So we have this drug called lidocaine. All right, lidocaine is a sodium channel blocker. Now, I don't really expect you guys to memorize that right now, but you'll get there, right? Through spaced repetition, body systems, think about scenarios, and then we're going to do some hands-on. So lidocaine would be our pure ventricular drug. All right. Another drug you guys probably hear about all the time, amiodarone, okay? So amiodarone, the cool thing about amiodarone is we think about amiodarone as a more ventricular drug. So I'll put amio down here. Amiodarone. There's many different drug calculations we can use for this. If I'm alive and I'm having PVCs, and let's say you don't have lidocaine, because not all ambulances in Arizona carry lidocaine. They carry amiodarone. So my amiodarone that I could use for my PVCs would be 150 milligrams. We put it in a 100 cc bag over 10 minutes. So here's 2 drugs that work in the ventricles, on your ventricular conduction system, okay? And it really just makes the heart less irritable. The good thing about amiodarone, is we can also use it for the atria as well, with certain atrial rates. Some physicians will use amiodarone for AFib. Some physicians will use amiodarone for SVT. We traditionally don't in the field, but you may see that. So if you ask yourself, wow, that's kind of weird, some drugs have crossover. So we could also write amiodarone up here for some specific conditions. And it's still the same rate, 150 milligrams over 10 minutes. And that's what's kind of nice about some of these crossover drugs. All right, so let's go over to the drug box and do some hands-on. I'm going to show you some really fast tricks of the trade. All right, so the first drug that we've been talking about is epinephrine. And the epinephrine comes in its own box, and it comes with these 2. You have the vial and you have the delivery device. Pretty simple. You can do it the cool guy way, right? And kind of flip them off at the same time. You have to have that look. National Registry and in real life says we have to dispel the air. And this is the really cool part, and something I want to talk to you guys about, because I've seen this and I have actually done this myself. This CarpalJet is made for a needle or needleless system. Most of the systems now, the Select 3s, the IV tubing, are a needleless system. So all you have to do is pull off this yellow cap here, and now it's ready for the needleless system. You dispel your air, get your little bubble at the top, just like that, and now we're ready to go. This is the trick, all right? So you look really smart. You hook this on, it screws right into the needleless system, and you give your medication. However, do not just pull this out And I've been guilty of this myself. You pull this out, go, hey, I'm ready to throw this away in the sharps container. Well, this is still hooked on. Guess what's going to happen? That's right. All your epinephrine and all your saline that's hooked to it, or blood, is going to start shooting out. And it's usually about this level, so it's going to cover you. It's going to cover the floor. The patient did not get their medication. So when you take this out, make sure you screwed it in. You just put your finger right here, which is one reason why this cutout is made, and you just unscrew this, and it comes out together as a unit. If they only have a needle system, a needle port, that's easy as well. This just pulls straight up off here, and now if you can see, there's a repressed needle in there, depressed needle in there, that you can't really poke yourself. You'd have to actually try. And then you just hook this up to the needle port, slowly infuse your medication, and then just pull this out as a unit. This is a sharps, so this must go in the sharps container every time. Well, what if you don't have this? What if, for space in your drug box, this was all you had, was your box and the epinephrine? Well, how can I get this out? This is how we make push dose epinephrine, for example. I would just take my 10 ml syringe, I would alcohol the port right there, and I would just stab my 18 gauge or my blunt fill needle, this is a 1 1/4 needle, right through my blue stopper, hold the medication up, and I can literally just draw this medication out. And I just chase this syringe with the port. And now I can draw up my 1 milligram, 1 to 10,000. A very common drug we give, again, that we talked about on the board is adenosine, okay? Your adenosine comes in 6 milligrams per 2 ml. This is one delivery device. Some ambulances may only have the vial, the multi-dose vial that you have to draw out of. There's a lot of ways you can give adenosine. Here's a really quick trick of the trade. This is what I did just last week at the hospital. This is what I do in the helicopter. Is I take a 20 cc syringe with, once again, my 18 gauge blunt fill needle. I would put my 2 mLs in my syringe. Okay, so now I have 6 milligrams of adenosine in my 20 ml syringe. I get all the air out of it. I can hook this to my needleless port, or if you had to, you could alcohol the bottom, spike your bag, and then I fill this up with 18 cc's of fluid, of normal saline. So now I have 6 milligrams followed by an 18 ml flush. I pinch the line, I hook it as close to the patient side as possible, and you rapidly give your drug. So now I've given my adenosine, followed by an 18 ml flush, and I can just keep my bag wide open, and it just keeps flushing the IV in. Adenosine has a half-life of whatever literature you read, about 6 to 10 seconds. Once it hits the blood, once it mixes with the plasma, not once you make it, or else it would be done as soon as they put it in the syringe. So that is a really fast trick of the trade. What that can do is that can alleviate the time setup to try to find a 3-way stopcock. You need to have an IV with 2 ports on it, or you're hooking the 6 milligrams on one side, the 10 mLs on the other side, and you have to toggle back and forth with this 3-way stopcock. That is a very acceptable way to do that. We are going to teach you that here at Pima. But this is another way that a lot of the PharmDs, myself, and the physicians, we give adenosine this way. So your 6 milligrams, which is 2 mLs, in a 20 cc syringe. If I wanted to do 12 milligrams, so I have my 12 milligrams adenosine, because let's say the first dose didn't work. Then I just fill up 4 cc's, and now I can still do 20. This is a 25 cc syringe, and just fill this all the way up with saline. So now I've got a 21 cc or 21 ml big bolus behind that adenosine. Hook it as close to the IV port into the patient as possible, and most likely you're going to get the results you're looking for. So the purpose of chasing the adenosine with a 20 cc flush is because it has such a very short half-life. We're talking 6 to 10 seconds once it mixes with the body's plasma. That if you just push it alone, depending on the heart rate, depending on their volume status, their hypotension, it takes a long time for that medication to get to the sinoatrial node and the AV junction. And the AV junction is where adenosine works. It's the most potent AV nodal blocking drug we have, both in the hospital, pre-hospital, and in the helicopter. Since it has such a short half-life, you really want to get that drug to that AV nodal junction as fast as possible, hence the reason why you always want to do a big flush, especially if it's in a tibial IO or if it's in the left hand. You really need to flush that medication up so it gets to your target area, which is your right atrium. Multi-dose vials are an everyday part of our life, right? We have multi-dose vials that have high concentrations, that have lower concentrations, and the nice thing about it is a multi-dose vial, so you can titrate these drugs. Instead of just giving 1 milligram of epinephrine, for example, let's use Narcan, a very common drug we use in Tucson. The cops have it now. Everybody's giving Narcan to everybody. And let's take this one for example. This is Narcan, or naloxone hydrochloride. It's a 10 ml or a 10 cc multi-dose vial. So there are 4 milligrams in this vial total. But the doctor says, I want you to give 0.2 milligrams. Well, just like I was telling you before, if you look, it's a 10 ml multi-dose vial, but it tells you underneath the what it is, naloxone, 0.4 milligrams per ml. Well, it even tells you they're out. IM, IV, sub-Q. You can give naloxone any way you want. But the doctor's ordered 0.2 milligrams. Say this is a child, for example. Well, how are you going to do that with a 3 or a 5 or a 10 ml syringe? You're not going to have any remote accuracy. So what we can do, and what I highly recommend, especially for every pediatric drug that you're going to give, that's over 1 ml especially, is you grab these little 1 ml syringes. And it has on there, as you can see, 0.1, 0.2, 0.3, 0.4, all the way to 1 ml, okay, or 1 cc. It says both on there. So the doctor's ordered 0.2 milligrams. Well, I know if it's 0.4 milligrams per ml, I need to give half of that. So the way I can be the most accurate, here's my 0.5 cc or 0.5 ml on my TB syringe or my small 1 ml syringe. I get my alcohol pad, I would clean the top off, and I would, however much I'm taking out, I would inject that much air. And this serves for 2 purposes. I know I need to give 0.5 ml, so I'm going to pull this back to the 0.5. Here's spaced repetition once again to help reduce medication errors and not give too much. Okay, I like to do a 2-handed technique, so my hand's touching, so I avoid my needle sticks this way. Okay, instead of trying to guess, I always put my hand here to stabilize, put this right up here, or you can have your assistant do that, but sometimes people get very nervous doing that. I'm going to inject, I'm looking once again, my 0.5. So I injected 0.5, I'm going to draw back 0.5. Keep it straight up, get all the air out of it. I now have my Narcan at the dose that my physician wanted, 0.5 mLs or 0.2 milligrams. Almost impossible to have a medication error, and especially when we're talking about our vulnerable ones, our little pediatric patients. So this, at 0.5, you can clearly see I have the right dose, the right concentration, the right med for the right patient, and it's going to go IV, so I have the right route at the right time. And I've secured my 5 rights, I've secured my drug, I've secured my dosing for not only my documentation, but for my effect. I know I've given 0.2 milligrams of Narcan. At Pima, we have these drug boxes available. They're available during your lunch break. Let your instructor know. When we're talking about pharmacology, when we're talking about body systems, if you're that learner that needs that hands-on, number 4, that hands-on learning, ask, can I borrow this? Can I see this? Can I play with this as we're talking about overdose? Put your hands on this drug. Look at this drug. There's multiple variations of the delivery, and we take these medications right from the field. So you will see either this on your ambulance, or you'll see this on your ambulance, or you'll see the 2 milligram Carpojet on the ambulance. But ask to see this so you can play with these drugs, so you can figure out, for example, how the MAD device works. We have them right here for the atomizer. We don't mind opening this up and have you spray this. This is actually saline in here. This isn't Narcan. So play with these drugs, handle them, practice, supervise, how to draw the drug out of there. Go over scenarios, number 3, with your friends. As we're talking about body systems, if we're talking about RSI, for example, well, see what succinylcholine looks like. Have the atomic in your hand, so when we're doing the lecture at 0.3 milligram per kilo, you're looking at the doses and going, okay, this is 20 milligrams per 10 cc's. And you can start touching it and feeling it and seeing what the labels look like. So it just makes it a lot easier for you. Pharmacology can be very difficult. A lot of the students say this is one of the hardest blocks in paramedic school, and we get it. There's a lot of meds, but we have so many resources available for you. I would say definitely take advantage of it, okay? All right, so we've talked a lot today. Let's wrap it up. Guys, pharmacology, this is serious. We are given the authority, the autonomy by offline medical direction to give drugs that can literally paralyze and kill somebody. You'll see in the RSI lecture that they say RSI is very controversial because if I did it wrong, for example, I could literally kill somebody if I can't get their airway back. Or if I paralyze the wrong person using succinylcholine on a patient that has a K of 9, I'm going to kill them, okay? And it's very hard to justify, and I could probably lose my cert. So when we talk about pharmacology, guys, this is a very serious subject. The people in the hospital, the nurses, the CNAs, they fall under medical direction. They have direct control. The physician says, I want you to give this medication at this dose, okay, at this time. Being a paramedic in the field, this is all offline. We have to think through the process. We have to be right. Medication errors, unfortunately, in a pre-hospital environment, kill patients. And they kill our family members. Med errors is one of the most highest occurrences that happens in the hospital is through medication errors. Okay, now let's bring that into the pre-hospital realm. We're working, our physicians are trusting us to make the right decision because it's their license at the end of the day. Ultimately, it's your cert. So when we talk about pharmacology, guys, this is not just willy-nilly. This is something you have to commit to memory, that you have to be sure I'm giving the right drug to the right patient at the right time, the right route, okay, the right dose, because medication errors can be fatal. So scenarios, and what I mean by that is actually think of some scenarios. So a common we talked about already, cardiac arrest. You get on scene, you see a bystander doing chest compressions, you clear them, sure enough, the patient doesn't have a pulse. Or they're in VFib, even more fun, right? So we know epinephrine, 1 milligram, 1 to 10,000, which is your 1 milligram in 10 cc's. I know I'm gonna get a line or an IO, and I'm gonna slam that epinephrine in pretty quick. I'm gonna defib them if they're in VFib. I'm gonna give more epinephrine every 3 to 5 minutes, and now I've got another drug I can use. Amiodarone, 300 milligrams, rapid IV push, always with that saline bolusing in, especially through an IO, always have that at bolus. I'm gonna give my other drugs, I'm gonna give my epinephrine again, maybe I'm gonna check H's and T's. Oh my gosh, their glucose is 35, so I know I'm gonna give an AMP of D50 during my compressions. So there's 3 drugs that I have to give right off the bat. Boom, you clear that scenario, next thing you go to a difficulty breathing. Severe asthmatic, they're tripoding, they're grabbing at you when you walk in the door, and you're like, oh my gosh, look at this asthmatic person. I'm gonna get them on high flow. I know they're gonna need a nebulizer with Atrovent and my albuterol. I'm gonna pour them in the bowl right there. I'm gonna start them on an albuterol Atrovent nebulizer. I need to get a line. There's a lot of drugs I can give for asthma. I know, man, next thing I'm gonna grab for is my 2 grams of magnesium, because that's a drip over 10 to 15 minutes. I need to get that mag in there now to work as that tocolytic effect that we'll talk about in pharmacology and the asthma. But already I've broken that body system up to pulmonology, right? Now I've just got that body system, I'm thinking about those lungs. So I've got my albuterol Atrovent going, I've got my mag drip going. Maybe they're so bad I need to give that 1 to 1,000 epinephrine at 0.3 to 0.5 milligrams in their thigh, in their vastus lateralis. But I'm not done there. I'm transporting code 3, their wheezing maybe starts to get better. I have Solumedrol that I'm gonna give, 125 milligrams for your standard adult dose, or 2 milligrams per kilogram for your pediatric dose. Now I've just given 4 meds in a matter of minutes. And lo and behold, that kept that patient from needing to be RSI'd. Which brings me to a third scenario. We'll talk about the RXI lecture. And not every medic in Arizona RSIs, but you're certainly going to see it in flight. You're certainly going to see it at some agencies. So, and definitely at the hospital. So we have a rollover with ejection. The patient's having seizures on scene. You've got your high flow, you've got your line, you're putting them in C-spine. We're off the X. We're going code 3 of the hospital. You have a 15-minute transport. Their pupil is blown, meaning their right pupil is fixed and dilated at 7. Their left pupil is 3 and sluggish to your pen light. Well, they probably can't control their airway at that point. Their sats maybe are dropping, so I know I need to RSI this person. So if you have the guidelines, I can use a little fentanyl, which is your synthetic narcotic, to help blunt the ICP effect at 100 to 200 mics, slow IV push. Now I have my etomidate, or my ketamine. My etomidate, I know is 0.3 milligram per kilo, with the average adult dose of being 20 milligrams of etomidate. Maybe I'll use ketamine. I happen to love ketamine. I use it almost exclusively in flight. At my 1 to 2 milligram per kilogram, slow IV push. Those induction agents are slow IV push. Well, now I need to paralyze them. The most common drug we use to paralyze somebody in Arizona for a paramedic is succinylcholine, which is a depolarizing drug. And we'll talk about that later, but you can remember a little tip of the trade. It sucks to be depolarized. And that's how I remember it. That's how I teach it for the exam. You know, if it says succinylcholine is a non-depolarizing or depolarizing drug, it sucks to be depolarized. I know it's a depolarizing drug. I give that rapidly. I wait 45 seconds to a minute, and now my patient is in perfect condition to place that AT tube without causing a gag reflex. And now I need to follow up with maybe a little Versed for post-intubation pain and sedation. So now I've got my Versed on board, I've got my fentanyl, I'm giving every 12 to 15 minutes. We've just given 5 drugs in the matter of 5 minutes. But that's where you guys will get. And I remember all this stuff because I do spaced repetition. I think about the body systems. We just talked about TBI, that was isolated to the brain. We've just given 3 good scenarios where you've given a lot of high yield drugs to a high yield patient. And then the hands-on approach, right? We'd have these drugs in our hand as we're reviewing them sitting here at Pima. Here's my etomidate, here's my sux, here's my midazolam, here's my fentanyl, here's my epinephrine, here's my 2 grams of mag, which is in a bag. But you may have to make it. So we're gonna show you all that. Guys, I think you guys will do great in pharmacology. Okay, so now we're done. We're gonna do the take-home points. Take-home points for pharmacology. The study of drugs, spaced repetition, all right? Slow bursts, gradually escalating how many times you review it. Review one drug, one indication, one class, put it down, come back to it, and gradually increase it. Body systems. Guys, this is one body system. This is the heart, okay, that I've used for this example. But for every body system, you should be doing this. You know, make it yours. Draw out a human body, right? Cut the brain in half. Cut the body systems in half. We have respiratory and we have cardiac. We have genitourinary and we have the abdomen. So cut these things in half. Learn what drugs work in that body system alone. I think that could really help you nail pharmacology and be really good in the field. Scenarios. Think of scenarios. Go over scenarios with your classmates, with your buddy. Hey, at lunch, hey, let's go out. Let's get out of Pima for a little while. Let's go to lunch. But let's talk about a scenario. What if that person walking down the street collapsed and it's 110 degrees outside and you take their pulse and it's 160? Would you be thinking SVT? Would you be thinking AFib with RVR? So go over your scenarios with your buddies on your own time, even during commercials when you're at home. And then last but certainly not least, the hands-on portion. Pick these drugs up. Draw these drugs up. Think about when you have scenarios, how many milligrams I'm going to need for that SVT. Well, let's talk about PEETs. How many milligrams am I going to need of adenosine for that SVT for that kid? At 0.1 milligram per kilo for your first dose, or 0.2 milligram per kilo for your second dose. All these things put together, hopefully guys, should make your pharmacology experience here at Pima a lot less stressful, and you actually retain it. So when it comes time for you to use this, it's serious, it's go time, it's show time, and you're gonna save a life. What we do makes a difference. Thanks.